Good afternoon. Thank you for joining us for today's monthly press conference. Before I introduce the Secretary, I'd like to go over a few media ground rules. I ask that you raise your hand if you have a question. I will then call upon you, and I ask that you walk to the microphone that you see in the front. Once at the microphone, you may remove your mask to ask your question. You have the opportunity to ask 2 questions and a follow-up at the microphone. I thank you for following these ground rules. One thing I'd like to announce before turning it over to the Secretary is that today's presser and those moving forward will stream to our VA teammates and external audience. I must thank the VH broadcast team and VA leadership at all levels for helping us achieve this feat. This effort is a major step for VA as we continue our commitment of transparency to our stakeholders. And with that, I now turn it over to the Secretary.
Awesome. Terrence, thanks very much. Good afternoon, everybody. In a minute, Dr. Mark Upton will be updating you on a topic we've discussed in here in the past months, a topic that I know many of you care a lot about, and I know I care a lot about, and that's our community care program. Mark is now acting in the role of Deputy Undersecretary for Health, but he has helped lead the community care program for the last 4 years. So he's a font of knowledge on this important part of our care. I have several updates for you as well, but before we get to any of that, I want to begin by recognizing that this is a difficult time for many veterans. The 20th anniversary of 9/11 was just 4 days ago. The war in Afghanistan ended just 16 days ago. 13 service members, 13 heroes, were killed in Kabul just 21 days ago, some of whom are just now being laid to rest in our national cemeteries. Fires are still burning in the west and much of the south. The East Coast is still recovering from Hurricane Ida. And on top of all of it, the Delta variant continues to lead to increases in infections, hospitalizations, and deaths across the country, including right here at VA. Amidst all these challenges, we've been sending one important message to veterans, and I want to reiterate it today. We're here for you. Our VA team, some of whom were themselves in the Pentagon or at Ground Zero on 9/11, many of whom saw combat in Iraq and Afghanistan, know firsthand what veterans are going through right now, and they're here and ready to help. So to anyone who is struggling, please know that you do not have to go through this alone. Whether you'd like to speak to another veteran or a chaplain, talk to a therapist, call or text our crisis line, visit one of our vet centers, or access any of VA's mental health services online at mentalhealth.va.gov. We're standing by to get you the help you need. Now, on the topic of mental health, I'd like to touch on our efforts for Suicide Prevention Month. We released our annual report on veteran suicide last week, which showed the veteran suicides decreased by 7% in 2019, down to the lowest total since 2007. But of course, that positive trend does not mean we can let up. Quite the opposite, actually. And to that end, we're in the midst of an aggressive strategy to inform veterans of mental health resources at their disposal. That includes a daily vet resources check-in on YouTube and the Veteran News Network. That's a network for vets, families, caregivers, survivors, and employees. A paid advertising campaign on gun safety, which we rolled out this past weekend, and a partnership with the Ad Council to get the word out about mental health resources. Because one veteran suicide is one too many. For that reason, we're working tirelessly this month and every month to help our vets get the help they need before warning signs turn into tragedies. We're also continuing to do everything we can to help vets through the pandemic. Unfortunately, VA saw a 272% increase in COVID-related hospitalizations this summer, largely due to the Delta variant, which has made our push for vaccinations even more urgent. We're continuing to meet vets where they are to get shots into arms. In fact, today, as we speak, we're hosting a vaccination event for deported veterans at the border between Tijuana and San Diego. In the same vein, I want to thank the President for his decision last week to require vaccinations for all federal employees, federal contractors, and companies who employ 100 or more workers. There's no better way to keep our employees and veterans safe. Now, while we work on implementing the President's vision, the vaccine requirements that we've discussed at length in this room and that we put into place in July will remain in effect. That requirement has already proven to be effective. 88% of VHA employees who have attested to their vaccination status are now fully or partially vaccinated. And based on our employee health record system, documented vaccinations have increased 9% among VHA employees since these requirements took effect. We'll keep you updated on our progress as we approach the October 8th vaccination deadlines for those 2 VHA mandates. Quickly, a few more updates. We've started processing claims for the new presumptive conditions related to toxic exposure for Vietnam War vets and Gulf War vets. This is important news, and VA has begun an aggressive effort to hire 2,000 more employees to process these claims. It's an important step because, due to the Blue Water Navy claims, we've seen a 16% increase in the claims backlog from July. And we anticipate the backlog to further increase this fall as we process claims for presumptive conditions from Vietnam and the Gulf. Next, I was grateful to see the Build Back Better agenda pass on the House Veterans Affairs Committee this week. It's a critical framework, including $18 billion to invest in VA's aging infrastructure, our workforce, and other support structures that serve veterans, and I hope to see it on the President's desk very soon. We'll also have some more good news for you next week, including around the 10th anniversary of the repeal of Don't Ask, Don't Tell. Nothing specific yet, but just a heads up. And I'd like to acknowledge that today is the beginning of Hispanic Heritage Month, where we recognize, as President Biden said so well in his proclamation, that Hispanic heritage is American heritage. This month in particular, we will focus on how we honor past contributions and sacrifices of our Hispanic veterans, VA employees, their families, caregivers, and survivors. It's our job to serve them as well as they've served us. Entonces, a nuestros empleados de VA y veteranos que están mirando en sus casas, feliz mes nacional de la herencia hispana. Gracias por su servicio. Y estamos alegres por celebrar con ustedes. Lastly, I want to say a few words. I want to thank our VA employees who are watching this press conference live for the first time, thanks to Tanya Bradsher and our technical team. Not to mention Terrence, Kayla, Melissa, Mark, Gary, and others. VA employees have been on the ground for every emergency that's happened over the past couple of months, helping vets where they need it most, when they need it most. I know this is tiring for our VA colleagues. I know how demanding it is, and I know how hard you've been working for 18 months in the pandemic. For example, in response to Hurricane Ida, more than 180 VA employees have deployed to Louisiana as disaster emergency medical personnel, DEMPs, we call them, including, remarkably, the man you'll hear from next, Dr. Upton, who was one of the first medical professionals to answer the call for volunteers, deploying to Louisiana, leaving his wife and 2 young daughters at home while he went to take on that important work. That's the dedication of VA staff every day at every level. And it's why our country, vets, and VA are so lucky to have them. That's all I got. Thanks for your time and for all you do. With that, let's turn it over to Mark to cover community care for a little bit, then we'll get into your questions.
All right. Good afternoon, everybody, and thank you, sir, for the kind introduction. Really happy to be here with all of you, and just as a leader in the Veterans Health Administration and a provider that's really privileged to continue to see veterans clinically, I was really struck by the comments that the Secretary said at the beginning. This is a difficult time for veterans, and it's a challenging time in healthcare with the COVID-19 pandemic, surges of the Delta variant, and the natural disasters that were just referenced. And I just want to reemphasize that VA is here for veterans, and we care deeply about making sure that you're getting the care that you need. And we have a lot of resources available through our medical centers, our vet centers, the suicide crisis line for those that need that assistance, and many other that are available. And it's just very important to me to just reemphasize that we're here for you now. We're going to continue being here for veterans, and look forward to continued conversations as we go forward. With that, I wanted to touch base on community care, as the Secretary said. When we look at access overall for our veteran population, it's a combination of the great work done in our VA medical centers, the virtual care that VA offers, as well as the care from our community partners. And I've certainly been heavily involved in our community care work for many years, and I'm very grateful for the work that our providers in the community provide. And we thought this would be a good opportunity just to give you an update on some of the key things that we've been tracking as we look at the progression of community care, both after the Mission Act and now during the pandemic as well. So for those of you in the room, you have a packet of a couple slides. There'll be a slide displayed likely behind me or on the screen. But for those of you that aren't able to see everything, I will talk through them in detail for you. So the first thing I wanted to talk about is the first slide that those of you in the room have in front of you, which really looks at referral patterns over time for community care. And when we use the term referral, it's a request from a clinician for a veteran to receive a type of service that ultimately gets approved and referred out through the community. And that's a good way for us to look at kind of the volume and the overall growth in the program over time. And there's some key points here that are kind of shaded in the graph, but the take home is that prior to June 6th of 2019, we did see a month-to-month gradual growth in community care. But after June 6, 2019, which, just to recap for the audience here, expanded eligibility criteria through the Mission Act, which gave veterans more options to choose to go to the community if that was best for them, created an urgent care network that is available for veterans in the community, as well as internally in VA, we worked on ways to streamline the emergency care reimbursement and approval process that has historically been challenging for veterans, and that's something I'll touch on at the end as well. But after that date of June 6, 2019, we did naturally see an uptick in the amount of care that was referred to the community. And that uptick really persisted up until early spring of 2020, in the midst of the early stages of the COVID-19 pandemic, which, just as in the private sector, health systems were hit hard. But that dip was pretty brief and then rebounded to pre-pandemic levels overall. I think the next big inflection point that I wanted to share with all of you was really spring, March of 2021 of this year. As we can recall, at that point, that was one of the first times the country had come out of its last major national COVID surge. And I know the Secretary and my colleagues in VA have talked about the care and the pent-up demand that we had worked to achieve and continue to work to achieve within our system as well as in the community. And really, as we address those continued care needs, you'll see that the referrals to the community have been at really the highest levels that they've been and continue to be that way, and it's something we're watching very closely. The other piece that then continues past this August timeline that we'll have to be tracking closely is the impacts of the pandemic again now with the Delta variant and the surges that we're seeing. But we continue to make a very heavy push to ensure veterans are getting the care that they need. I'll go through the next slide pretty quickly, but certainly happy to answer questions after I finish. The second slide that all of you will see is just the growth in referrals, again, those requests for care that I had mentioned before over time, as well as the number of unique veterans, so individual veterans who are enrolled in our system that have had at least one referral for community care. That's grown from about 1.2 million unique veterans in 2014 up to 2.2 million and growing now in fiscal year 21. So community care has grown over time, both from the Choice Act and now the Mission Act, and as we continue to use all available options to get veterans care, and just wanted to kind of share the scope of what we're seeing. On the next slide, you'll see a discussion about some of the expenditures, because one of the things that we certainly track operationally is not only who's going out, how much is going out, what are veterans going out for, but how much does it cost? And as we look through the numbers here, There's always going to be some month-to-month variation, but we certainly see about on average, it's about $2 billion we're expending on community care programs per month, which is a pretty substantial amount of money and certainly has grown from prior years. And I wanted to make sure that all of you had visibility into that because it's important to us. Finally, on the last slide, this goes into a little bit about what is going into the community. And when we think about community care, there are a few different ways that we look at it. One is emergency care. So veterans that have an emergency, we want them to get seen at the closest provider that can care for them. Urgent care, as well as care that VA provides and care that VA doesn't provide, such as home health services or maternity care. So I won't go through this in detail, but I wanted you to see kind of the top categories that have received referrals that veterans are receiving, and just point out at the top the significant amount of emergency care. So that's both our number one volume in terms of care going out, as well as cost. So certainly an area of focus for us as well. So with that, I will pause. My goal here was to hopefully share some of the trends that we're seeing, the key information that we've learned, and hopefully you take away something new, and happy to answer questions.
Mark, thanks so much. Thanks, everybody. As we've been trying to do in these monthly press conferences, we want to, bring you people who are smart, since I'm not as smart as somebody like Dr. Clancy, who's been with us, or Dr. Stone, or Mike Frew, or Dr. Lieberman, or Dr. Upton. But the other is to just let you know this is obviously a relevant public policy question, particularly as we head into budget season. Both, that is to say, finalizing of the appropriation for FY22, but we're also finalizing our FY23 request at the moment. So we're wrestling through all these questions, and I know that this will end up being an issue that may not be something you write on immediately today or this week even, but we want to make sure that you feel like you can get the kind of information that will help inform your readers and your editors, and most importantly, our vets, their caregivers, and their families as they're making decisions about where they seek their care. So with that, why don't we get into your questions? Yeah.
Adam Patterson, Government CIO Media. Secretary McDonough, you'd mentioned that the ongoing disasters throughout California and the Gulf Coast, and it looks like we're unfortunately entering an era where those will be potentially seasonal, wildfires, storm activity, and it sounds like VA had dispatched emergency support to Ida, and especially medical support. Are there potential plans or discussions within VA to create a more formalized response corps to these kind of climatic disasters, especially in terms of, say, medical care?
Yeah, excellent question. So I'd say two things about that. One is that as we are looking at our infrastructure investments, as you would expect us to be doing quite diligently, and in as much as the president has fought really hard, and now the House has started the process to get us this $18 billion in extra investment in our infrastructure, which I hasten to point out to you is the average hospital in our system is 59 years old. The average hospital in the private system is 12 years old. I'm not good at math, but one is much older than the other. The fact is that as we look at that infrastructure investment package, we're taking a very serious look at how to make it consistent with requirements in a changed climate, one. Two, we have a very formal process by which people like Mark, I point out again, clinicians in our system can sign up through DEMPS to deploy. And we're doing that both as it relates to intense weather events, but we're also doing it in the context of COVID. Right now we've seen we're seeing a kind of a tick down over the course of the last week, so I hope that is a trend that continues. But over the course of the last 6 weeks, we've seen a sharp tick up of what we call staff unable to work due to COVID. This is the data we get every morning, and we've seen a very sharp slope up on that number of staff. So DEMPS personnel like Mark, have signed up to deploy into places, as we've talked about in this room before, impacted by COVID. That process is the same process by which we deploy people for these weather events. Over time, for example, as we consider questions like the Air Commission, we are factoring into that very much this fourth mission role, which is what the DEMS perform for us, fourth mission assignments, and making sure that our infrastructure, as well as our personnel staffing requirements, take into account those requirements. So I hope that's helpful, but that's how it answers the question.
Great, thank you.
Leo. Hi, Leo Shane with Military Times. Two questions for you about employee-related issues. First, you said 88% of VHA folks so far have taken the vaccine. That leaves 12% with just a couple of weeks. Are you anticipating, 10% of the workforce there not having vaccines?
Yeah, sorry, I thought you were going to ask both questions.
I can ask the second one if you'd like.
No, I'll go ahead and then you come with your second one. So let me kind of give you a little granularity for a second around the numbers. I cited two different numbers, and I want to just be as clear as I can on what they are. One is attestations, okay? So we're using as the global number of VHA personnel subject to the mandates to be 380,000 employees, okay? Of those, 82% have completed their attestation, okay? So there's 18% yet who have not yet completed attestation. And in the context of that, basically 88% have said they're either fully vaccinated or on their way to getting vaccinated. Of the remaining 12, the options available to those personnel are a religious or a medical exemption. We don't have enough clarity yet to see into the data to find out how many such exemptions are being sought. I think at the individual medical center level, we may have some visibility into that. I just don't have it. So at the end of the day, we're going to use this next period, Leo, to continue with the remaining 12% who haven't attested, as well as those who haven't gotten the vaccine, to provide education. We're working with influencers to try to make sure that we're getting information to them, to include docs like Mark, to include our union partners who have generously agreed to work with us to communicate to the workforce. And then we still have the tools that we've talked about in this room before, 4 hours of extra annual leave upon proof of vaccination, and 2 days of leave, sick leave, to respond to any kind of side effects that one might get. If at the end of all that process, somebody is still refusing to be vaccinated, they will be subject to what we call progressive discipline. And the goal of that discipline is to get people vaccinated. And the last thing we want to do is have to fire trained personnel. So that will be a very clear process implemented at the supervisor and local level. The goal of which is to get people vaccinated, provision of education, and so forth. But if at the end of that progressive discipline, they've still chosen to not get vaccinated or get an exemption, they will be separated from federal service. Now, I'm not in a position yet to say how many that might be, right? But we're making preparations to do this for the simple reason that the best way, as I've said to you guys many times, to ensure safety for our veterans is to have those personnel vaccinated. And so our goal is through this process to get to 100%. And we have experience with this, both in terms of the development of the deployment of the vaccine, but also the deployment of the disciplinary action with the flu mandate from last year. So we're going to use all those tools and get to the end of it. I hope we get to 100%. If we don't, then we have this process that we'll follow very closely. And we'll be ready to take steps that we have to make sure that we have the personnel on staff to take care of vets.
Okay. And you also said with the benefits issue, you're looking to hire new personnel to help with
Yes.
some of those claims. How bad do you think that claims backlog is going to get? We've seen that skyrocket in the past. Should veterans groups and veterans be preparing for another just dramatic spike? Because even if you hire folks, it takes some time before they
Excellent
can
question.
process.
Yeah, excellent question. There's the reason that we can see very clearly to a period when it's going to tick up again is because you recall how we define backlog. Any claim that's pending for more than 125 days. So the next time this will tick up is 125 days from the period at which we started the claims processing from the 3 presumptives that Congress passed last fall. And so we have see very clearly to when that date is. We see less clearly to the number, but we're in the field fulfilling those claims now. We want to keep warning veterans about what to expect so that they see what's coming the same way we do. But our concern about it is significant enough that VBA is in the field right now hiring these 2,000 personnel. We made sure that we went to talk to Congress about that because this also is impacted by the fact that we are now paying claims for the first time to Gulf War veterans for toxic exposure for 3 presumptions. And we want to make sure that we can do that in a timely way. So we'll keep communicating to you about the timing of it. We'll make our best estimations on the numbers that come with it. We think that we're staying ahead of this so that we don't fall into some of the big backlogs we've seen in the past. But any individual vet who's impacted matters very much to me, so I want to make sure we're communicating about that and preparing for it.
Great. Thank you.
Thank you.
Good afternoon, sir. Thank
Hi,
you
Ellen.
for doing this.
Yeah,
Ellen Milheiser with Synopsis. Couple of questions.
Sure.
Yesterday during the reconciliation markup at the VA committee, the question came up several times as to why the VA should be getting $18 billion to build new buildings before the Air Commission comes out and says where you should be building facilities. Response?
Yeah, well, the Air Commission statute says that VA should continue to plan for and invest in infrastructure needs during the course of the commission itself. And so what we're doing is not only consistent with the statute, I think it's the word of the statute. I think it's also consistent with the spirit of the statute. I think, I was not here when the statute was debated and signed into law, but I think it's fair to say that one of the motivations for the statute is a sense that the VA infrastructure footprint is not sufficient. And maybe in some cases overinvested, and maybe in other cases underinvested. This stands to reason. What they did with the Air Commission is saying we should study that, and we're doing that. What the president is saying is we should invest in increasing access now. And he's been, I think, quite persuasive on this point. And I think the data speak for themselves on this, Ellen. I said it a minute ago, 59 years average age for a VA hospital versus 10 to 12 for the average private hospital. Our clinicians, great people like Mark, make that work in any case, but it's a penny wise, pound foolish way to invest, to continue to spend as much money as we do on non-recurring maintenance in older facilities, rather than investing in the world-class facilities that our vets deserve.
So that leads to my second
Mhm.
follow-up. How much of that $18.5 billion will be going to whole new facilities or new leases, and how much to chipping away at the non-recurring maintenance backlog?
I forget the specific numbers, but I think I think at the end of the day, and again, I haven't looked closely at the completed markup from the other night, but I think about $15 billion overall is going to infrastructure of the 18. Of that, some portion, I want to say $3 billion is going to immediate needs. The remaining, let's say 12, goes into our strategic process to build new facilities in high-need areas that's, established, well-briefed to Congress, clearly understood by all our stakeholders.
Okay, my second question.
I think it's your third.
Topic. In the Federal Register yesterday, y'all published a rule expanding the deadline for presumptives for Gulf War illness. I'm not sure I fully understood it all, but how does that impact the claims backlog that you know is coming due to the 3 presumptives of Agent Orange?
Yeah, so without commenting specifically on the rule yesterday, because I think I'm with you in as much as I think we both have imprecise understanding of which rule we're talking about, and I'm happy to have a conversation with you afterwards about the rule itself. Every decision we're making on rulemaking around or requests for information around or discussions with Congress around their interests in legislating is informed by what veterans who are in our care and are receiving benefits now can expect for that impact on them, as well as impact on them going forward. So what I'd say, that's a long way of saying we're taking each of these steps into consideration, which is why it's so important to me that VBA is in the field on this hiring effort now of 2,000 additional people. And we'll continue these conversations with Congress about what they want to do. We've communicated to them expressly on the questions that they asked about how the pending bills in the House and Senate would impact things like the backlog. We've answered those questions. We have answered those questions because we're constantly asking ourselves those questions about how we need to be in a position to continue in a timely way the provision of world-class benefits to our vets.
Thank you.
Thank you.
Hi, Mr. Secretary. It's Patricia.
Hi,
with
Patricia.
Military.com. You've discussed the VHA vaccine numbers, but all employees fall under
Yes.
the federal mandate, right? So could you give us an idea of how many
Sure.
non-VHA employees are fully vaccinated or vaccinated, and what their deadline is for getting vaccinated?
Sure. The deadline, I think, Patricia, is 75 days from the president's announcement, if memory serves. So whatever Thursday plus 75 is the deadline. Point one. Point two, on the question of vaccination in NCA and VBA. I'm going to give you these are rough estimates, and these are also attestations, okay? But as of this morning, we get these daily updates from our colleagues, and it's kind of fun, actually, because they're making really, really good progress. At VBA, with something over, something over 85% of people having attested, they're at slightly over 80% vaccinated with at least one shot, which is, if memory serves, high 70s, fully vaccinated, 3 or 4% in the process of getting the second shot. Okay, so that's VBA with about 85% of people having attested to their status. Of that, roughly 80%, slightly over 80% fully vaccinated. Vaccinated or fully vaccinated. NCA, slightly higher numbers, I think having attested maybe as high as 90%, but again, this is from memory. Something over 62 or 63% having attested to being fully vaccinated or halfway, partially vaccinated. So that should give you a rough order of magnitude. As we get those numbers firmed up, with confirmatory data, not just, and what I gave you earlier in my prepared remarks was both the attestation data plus the data from our records, our health records, which show an overall increase of 9% vaccination uptake among VHA healthcare professionals. As we get that data for NCA and VBA, we'll make sure we get it to you.
Follow-up would be, you mentioned that there's a spike in people being out
Yes.
because of COVID.
Yes.
Are you having to cancel appointments? Are there certain medical centers
Yeah.
that are really stretched thin? And
Yeah.
if so, you know, where are they and what are you doing to help patients?
Yeah, excellent point. So, so are there places where there's curtailments? The answer to that is yes. We have a kind of regular process where we're getting updates on curtailments. We obviously study that here, and we provide that information to Congress so that they're tracking to make sure that nobody's surprised by that, one. Two, I can't speak from the top of my mind here. I don't know, maybe you can, on any particular curtailments at the moment.
There's none major to jump out,
Okay.
but certainly I'm happy to.
Yeah, why don't you take that,
Sure.
and then I'll come back to the second part of your question.
Yeah, thank you for that. Certainly in many of the harder hit areas of the country that have been impacted from COVID, whether it be Florida, the Southeast, Texas, some areas in the Northwest, those are the areas we've been tracking very closely, not only just from the staff perspective, who are really important to us to make sure we keep them safe, but from the veteran population that are coming in and the need to shift staff sometimes to address the inpatient volume and the care that's coming in for acutely ill patients. To answer the Secretary's question and yours as well, there aren't particular areas that jump out as major curtailments or major areas of need, but we also do deploy the DEMS personnel, the group that I was a part of, to help when sites are in need. And that's another way that we can work across VA if there are people that are not in an area that's hard hit, can help relieve those areas that are harder hit, and it changes by the day.
Can you then say maybe a couple of words about how, if in a system where there may be some curtailments, if there's need to triage particular care, emergent care, urgent care, how we do that?
Absolutely. Yeah, the importance of care is very important, and we work with the local medical centers on the ground who are looking at what are the needs of their veterans, what are the impacts of their employees, and let's make sure, whether it's in these facilities or through our community partnerships, that when veterans have an emergent condition or urgently needed care, that we're continuing to address that. And one of the things that we're proud of that's taken a lot of hard work and dedication from the VA staff is for urgently needed care that's needed urgently, not necessarily emergent, but very close. We've been consistently giving that in under 2 days in VA and in the community throughout the pandemic, and that remains a focus for us as we go forward.
That's great. Let me just make one last sentence about this, and let's make sure we've answered your question, or you may have others. I think this is why we see in those community care numbers the trends that Mark pointed out. Fact is, we're spending and referring in the community at numbers greater than the budget anticipated, which I raise for the following reason. This is not a budget I wrote. This is not a budget Mark wrote. This is a budget that we inherited from the last administration. So at the moment, we are spending more in the community, referring more care into the community than the budget anticipated by the last team. I think that's because we're confronting emergent situations and urgent situations like the one that Mark's just talked about.
So on that note, will you be asking for more money from Congress?
We're in a regular touch with them about whether we need to kind of transfer money from different baskets, and I think we've talked pretty regularly with you guys about that. We don't have any current requests for transfers. We did have some over the course of the summer, which we talked about in some of our last briefings. But so the answer right now is no, but I just want to point out one other thing. We've seen consistent increases in the VHA budget over the course of the last several years. That has to do with the intensity of care, the intensity of reliance on our system, the complexity of care that our vets need. And so one thing very much on my mind right now is the FY23 budget, which we've just sent first draft over to OMB. And I think it's fair to say that that continues to see increases in the healthcare budget. So my specific, I want to be as transparent as I can here, which is why I'm being maybe longer in my answer. Do we have a specific request to Congress right now to transfer money? We don't. We've gotten some help over the course of the last several months. But our FY22 budget is up there. Hopefully they get that done before the end of the fiscal year. That includes an increase for VHA. and our FY23 budget we're working through right now, and I'm here to tell you that it's going to see an healthcare inflation increase there again.
Thank you, Mr. Secretary.
Thank you.
Thank you, Mr. Secretary.
Hi,
Donovan
Donovan.
Slack, USA Today. Couple of questions, more general. You've now had more than 6 months on the job. What are your general thoughts about the agency, and where do you see the biggest vulnerabilities and biggest opportunities for improvement?
So after more than 6 months on the job, I'm very impressed by the VA personnel, VHA, VBA, NCA. I'll say I was down in Quantico on Friday for a day of service commemorating we remembered 9/11 actually on 9/10. To see the great work of our NCA personnel in particular is super motivating. I will say though, I'm also mindful that and particularly mindful of this, that circumstances in which the VHA professionals in particular, but also NCA and VBA, are carrying out all their work in the context of the pandemic and in the context, think of Southwest Louisiana right now, impact of Ida. We have a lot of people who live down in those communities. They're working. Many stayed overnight for several days, more than a week, working in the New Orleans facility while their houses were torn apart, right? So they're doing this, and obviously everybody's doing it in the context of the pandemic, so it's really hard. Those are my first two observations. Biggest areas of concern, let me put it that way, are core course requirements. Are we providing world-class healthcare in a timely basis? Are we getting earned benefits in a timely basis? And are we continuing the customer care that NCA is so good at? That's where, if we're not delivering on those things, our core course requirements, and included in the timely access to care is mental health care, suicide prevention, then if we're not delivering on those, it really doesn't matter what else we're doing. And right now I feel good that we are, but this is one of the reasons I wanted Mark to come out here. I want you guys to be able to see, I want us to be able to show our homework in a transparent way and let you guys come to your conclusions about that.
Sorry, you said NCA?
NCA, yeah, National Cemetery Administration.
But more generally, you're talking about VHA or VA?
I'm talking about all three administrations. Basically, I'm saying, I'm making the following point. If we do not excel at our statutorily given responsibilities, timely provision of world-class healthcare at VHA, timely access to earned benefits at VBA, world-class customer care, and timely access to benefits at NCA. Whatever else we do, doesn't matter.
Thank you. And my second question is on, in the same vein, have you set any goals or targets, for your time, at least for this term? And if so, what are they? And also, can I get your thoughts on transparency?
Yes. So on my goals for while we're here is to continue to exceed expectations on the three course requirements, the ones I just talked through. That's full stop. Underneath the hood on VHA in particular, we have a particular focus on provision of mental health care and obviously on suicide prevention. We want to make sure that we continue the improvements there. And then an issue that we're spending a lot of time thinking about is how we amplify VA and VHA's traditional role in training new healthcare providers. The country has a terrific shortage of healthcare providers, particularly mental health care providers. We're looking closely at what role we can play in addressing that specific question. My view on transparency is, I said this to my team today, this is the first time I've ever been in a job that I can just talk about whatever I'm working on. Most of the time I had highly classified things in my head, and I was scared to death that when I talked to people like you, I was going to accidentally leak something. My view on transparency is I come out here once a month with my hands up to tell you what's on my mind and what we're working on. If you guys ask me questions, we answer them. We are kind of an open book here, I think, and that's the goal. So my guess is, though, you didn't ask me that question because you think everything is going really transparently and super well. So do you have any follow-ups?
Not really. I think that's great.
Okay.
Can you commit to releasing all the data on the COVID vaccines?
Yes. When you say all the data, what do you mean? What I can't commit to do is anything that I can't do under statute. So I'm not going to release privately identifiable information or information that in the context of our collective bargaining arrangements and stuff we agree with unions. But yeah, we want to make sure that we're providing you all the information that we can here. But again, if there's something in particular that you're worried about, I hope you'll let me know.
Okay, thank you.
Okay. Really? Okay. Oh,
Hi there. Wait, can I take this off?
yes.
Hello.
Hi.
Two issues. I was thinking about this budget conversation that you've been having, and are more people using the system because more veterans using the system that weren't using it before? Is it because their barriers to access are lower since the Mission Act was passed? I mean, whether it's community care or internal care, because I know all of us, we've watched the budget grow and,
Yes.
and sort of wondered, okay, so what is causing this exactly?
Yeah, so I think it's a really, really interesting question. And this is an active question that we're asking ourselves, and many of our stakeholders, partners are asking the same question. And I think it's a really good question. I think we should, consistent with Donovan's question, try to be as candid and transparent as we can as we answer these questions. So I think about it a handful of ways. One is there are new access opportunities with the Mission Act. I think emergency room care is one example. So in broad and straightforward answer to your question, are there new access opportunities? The answer is yes. Mm-hmm. What are the other access points? Well, vets come to us, they're very sophisticated consumers of healthcare, and they come to us for different things. And I want them to come to us for everything. And this is the argument that I want us to make in the context of community care, which is I want us to be world-class in everything. And I was just at a CBOC in Gaithersburg on Monday with Mr. Trone and Senator Van Hollen. And the experience at that CBOC for a woman veteran seeking care is very positive, i.e. the range of services there, from GYN to radiology to mental health services on site, is different than the experience of my wife, who travels around the northern Washington suburbs once a year to get to all of her appointments. So I want that experience to be the experience across the board in VA. And we can get there. There's challenges between, access in the front door, so we got to work that. My point is, though, that our vets choose us for select pieces. I want to make sure they choose us for everything. And that shows up in the data. Third point, the complexity of the care is increasing cost. Mm-hmm. So the unique veteran appointments may not be growing at a rate consistent with the overall budget, but it appears to us that the intensity of every incident of care increases cost. All right. Fourth and last, though, we have a set of actuaries that we've been working with, and Congress works with quite closely for many years now. And our actuaries actually over time have been pretty accurate. But we're taking a hard look now with them, or to ask them to go back and say, where are we misforecasting for cost? I said that was last, but I will make this last. Economic downturns, pandemics. We have more data on economic downturns than on pandemics. Mean demands and intensity of demands for our care in our system increase. Unemployed veteran loses his employer-provided care, comes to us for more care. So I think that's also in this. So I hope that's not too kind of not precise enough, but those are at least 5 trends that we're seeing that speak to this. But I think it's the right question, and I think it's one that we have to get our hands around over time, because Congress is pushing really hard on this. They've been great partners to us, giving us what we need, but they're also very focused on the fact that this is eating up a big portion of the non-defense domestic discretionary funding.
I mean, just one follow-up. I mean, so there's as you know, long been a debate about community care and whether it costs more than, for a patient to come to the VA system. And depending on your political persuasion, the answers are different. I mean, does VA study that at all? Or is it just too difficult to study?
No, I mean, I'd love to hear your answer to this question. But my answer to the question is yes, we're constantly studying cost per episode of care. Where time per episode of care, time elapsed, So yeah, we slice this data and look at it really hard in a lot of different ways. We'll hear from Mark in a second, but what I want to get to is a point where we are not where you just said we are, which is that depending on your political persuasion, you have a different view. I think there actually should be a way for us to get some data to find out what's the most, what's the pathway that assures us maximum access, improved outcomes. That's the basis on which I'll make every decision here I have to date, and I will continue to. And so we need data to make those decisions. But I don't know, Mark, how do you want to answer this?
Sure, and thanks for the question. It's certainly an important one, and I'll just echo that the focus on access, satisfaction, outcomes are exactly spot on to what we're looking at in the health administration. I think there are some complexities, right, when you look at how VA internal care delivery is set up versus a fee-for-service model in the community, but we have a lot of bright researchers, a lot of great analysts who work very hard to help us as we look at those various nuances involved. So it's not an easy thing to summarize, but it is an important question. I appreciate you raising it, and I think cost is always an important topic, as well as the overall outcomes for our veterans, and that's so important to us. And we certainly believe in what we do internally, but appreciate the work in the community, and it will be an ongoing dialogue for sure.
Yeah, I just give you one last kind of mildly philosophical point, which is the VA for a long time has been critical to American healthcare overall. We train 70% of the doctors. Our research agenda, I've said this before in this room, you can't open a newspaper today and not see that the only organization in the country dealing with long COVID is us. Okay? We had new published data today about the experience with hospitalizations and COVID in the context of the Delta variant. That's our data. So one of the things I'm urging us to think about, and frankly, I'm urging it because I hear it from our practitioners, our clinicians, is to not underestimate the impact of that on the overall healthcare system in the United States as we go into things like the Air Commission. And we think about how are we going to maintain the intense educational relationships we have, the important training role we have, the really important cutting edge research we do. And if we just, so those have to factor into all of these questions about cost. because what I think what we can't afford is to lose the fundamental role VA plays in our overall healthcare system.
Thank you.
Great. You want to pull the plug on that? And there's nobody else? I don't want to leave. Consistent with Donovan's focus on transparency, if somebody has an unasked question, I want to make sure we don't sneak out without answering it. Awesome. Okay. Thanks, everybody.
Well, thanks, gentlemen. Truly appreciate it. This concludes our press conference. Thank you for joining us.